So I'm Andy. I know some of you guys, one of the ED consultants, and I guess I have a half an hour to chat about traumatic. Go over that. And these are a suggestion, of course. I mean, I don't know how much the New Zealand resuscitation guys have in everyone's mind, but it just seemed very sensible to me. And so we went over. So step one, identify its life-threatening trauma, right? So in the ED, most of the time we get a little pre-hospital warning for that. So that's when our clock starts. And, you know, we get a bunch of stuff ready. And it's the same thing. We're talking about this red blanket. We're trying to push that information up to surgery and anesthetics as soon as possible. And so that involves a bunch of preparation things as well. And then decide that it's not obviously futile, right? You know, there's only one airway. There isn't a head and a body that both need intubation. There's some other things that it sort of need up. And then just again and again and again, it says, stop bleeding, stop bleeding, stop bleeding. This is all very basic. I don't need to tell you guys, but you know, they've switched it around where it's sort of CABC, so stop the bleeding. And you know, it's funny because you know there's been 100 years of practicing CPR and 50 years of defibrillation and whatever, and now sweet. And now I get to be more organized. But it's a real mindset thing. So I think most of the ED consultants, who are the ones I talk to, know about this, but not all the ED nurses sort of know that we're going straight to stopping the bleeding before we go to electricity and CPR and all that stuff. So whilst preparing this, it was somewhat eye-opening to be reminded. Can you guys hear me, or do you need this? Do I need to just shout?
You need to shout.
Hello? This isn't on though, is it? I like to shout.
You like to shout. We know that.
Come on, guys. You guys are very hey, is this thing hooked up to audio?
Yes.
Is there going to be, like, because I got a video. It's going to be sweet. Oh. Okay. It's upside down. Okay, great. So you've seen this, and we'll go over this. So first of all, they do recommend attempting it. It's not futile. You know, it depends on what case study you have, but you know, there are definitely case studies where it's a 25% survival rate. There are definitely case studies or case series where it's a 1% survival rate. Probably, you know, you sort of average, you look at it at a modern system such as Middlemore, it's probably about a 5% survival rate. So if, you know, things go well, you get a 1 in 20 chance of saving the guy after they're dead. And of course, you can change the denominator there and get that better by just taking penetrating trauma, just taking people who are dead for less than 10 minutes, just taking a few things. But it certainly isn't to fold your hands, this guy's dead, he was killed in trauma. At the same time, the New Zealand resuscitation guidelines say if it's longer than 10 minutes, it's likely to be futile. Now, that's not in every case. You know, you have a healthy person with a real active heart with a very clear indication, you can have a longer than 10-minute downtime. And there's plenty of examples of that in systems just like ours where you get people back for if they've been down for longer than 10 minutes. It's very case specific. But so step one, nothing should get in the way of stopping the bleeding. So that means don't intubate the guy, don't do chest compressions, don't do any of that stuff, stop the bleeding, especially external bleeding, which in theoretical is fast. And if you watch yourself or if you sim yourself, you think, oh, I can do everything at the same time. I can stop the bleeding and intubate. I can do chest compressions and stop the bleeding. It just is amazingly cumbersome to do anything else to multitask. You know, it's the same like data with people. Everyone thinks they can multitask, but in reality, people don't multitask all that well. So then if you can open the airway, they say, and I agree, you know, traumatic cardiac arrest, a basic airway can be adequate. It shouldn't get in the way of the other stuff. You can do advanced airways. If you do it, try to maintain C-spine, but don't let that stop you. This is all pretty basic. Restoration of blood volume, they recommend IVs. They still say, you know, you need at least 18 gauges. That's correct, but remember your first line is oftentimes for RSI drugs and for paralysis and for pain control, so a small IV is better than no IV. Don't go out of your way to just get huge lines if you can't get them, right? IOs, you know, we're now, you know, for a long time, the kid had to seize for an hour before someone put an IO in. We're getting away. We're much better at that than we used to be. And now in adults, we're putting IOs in pretty quickly as well in the ED. Do you guys have an IO up in anesthetics, by the way? Have you ever used one? Oh, sorry, an interosseous, you know, not just an IV stands for intravenous catheter. And yeah, you guys haven't. Do you ever use it? Probably not. Yeah, we use it. I don't know how often we use our IOs. Probably in kids, we use it twice a month, 3 times a month, and in adults, every month or something like that. I don't know. That's off the cuff. And then central lines, if you do use a central line, it should be short and fat. It's all basic, right? So hemorrhage control, direct wound pressure, proximal tourniquets. Now in the ED, not only do we have our bear hugger tourniquets and lots of hands, but we have these CATs, trauma tourniquets, in case for a mass casualty. We've sort of done that. Pelvic binders, all sorts of crazy stuff. Direct pressure can probably stop most wounds in an ED or in theater. Fluid therapy, they recommend that first bolus, and they recommend blood. If you have blood, give blood. They've sort of gone away from giving a liter of colloids first. They say you should have 1-to-1 FFP versus RBCs or 2-to-1, whatever, and then follow a massive transfusion protocol. Everybody knows, like in the middle of a trauma, trying to decide what you're going to give next is difficult. It's the exact opposite of the previous case where there's a smart hematologist telling you guys what to do. This is like a stupid ED doctor who likes to run things from the hip, and they agree with me on this particular case. If you do resuscitate them, go to 90. If they have a head injury, go to 110. Don't try to get normal blood pressures until the bleeding stopped. If the pH is awful, they really don't recommend bicarb anymore. All this stuff is somewhat old hat, but still you'll see people going away. They've gotten away with the regular needle thoracostomies to decompress tension pneumothoraxes. They say you need to just put a finger in or put a clamp in. Most of the time, and especially even here in Middlemore, a needle's not long enough, a regular IV cannula needle. And if you are going to use it, it should be a special needle that's long enough to go into the chest. And this is definitely what we're teaching in the ED, and all the surgical residents who will listen to us, we're telling them to put fingers in chest instead of setting up for an entire chest tube. Right? Ultrasound, they recommend ultrasound. Basically, if you have cardiac movement, you have blood around the heart, that's a really good indication whether it's penetrating trauma or blunt trauma. The ultrasound can really help you decide. Now, you don't need to look at the abdomen. It doesn't really matter if there's blood in the belly. It's blood in the heart that you want to look for and blood in the heart that you want to fix. They recommend against this needle paracentesis, which is what many people learn because A, probably that blood's in there because there's a hole in the heart, and if there's a hole in the heart, you need a finger on that hole. And additionally, it doesn't work that well anyways to remove that thing. Now, if you don't know how to do a thoracotomy, which most providers in New Zealand do not, you can try a needle paracentesis, but it's the caution against it. So, resuscitated thoracotomy, there's a lot of debate about this. I don't want to spend a ton of time in, but remember the goals is you decompress the pressure on the chest, which decompresses the pressure on the lungs, which decompresses the chest pressure on the heart. That's the goal, right? So in some of those case series where they have like 30% survivals from resuscitative thoracotomies, they probably could have gotten away with just chest tubes, right? So a thoracotomy does relieve a tension pneumothorax pretty well, but it might be a little invasive. So in theory, you should decompress the chest with a finger, see if they're alive, then open their chest to get to their heart. The second highest value move is to release the cardiac tamponade, which they agree. And then as you get down in this list, it gets harder and harder. You need more expertise. Truthfully, it's pretty easy to teach someone how to do one of these two things. This is a lifetime of skills, right? You can put direct pressure on a lung. You can twist a lung. You can do a bunch of stuff. Cross-cramping in order is somewhat difficult, and you get decrease in benefits. And then, open cardiac compression. They say it works better. It probably does. But isn't as good as just releasing that cardiac tamponade. So they mentioned you can do it however you want. You can do it from the side. You can do it from the front. It's better on penetrating and blunt, obviously, and it's better the faster you do. They also say the guy doesn't have to be dead to do a resuscitative thoracotomy, right? A guy dropping down in and he's got an expanding hematoma around his heart. It's not unreasonable to do it while they still have vital signs. Special circumstances, there's a quick section on crush syndrome, right? If they're crushed under something, just empirically treat them generally for hyperkalemia, which is pretty basic. If they got punched at 65 kilometers per hour in the chest, which they mentioned, it's commotio cordis, and they need regular CPR, defib, all that kind of stuff. And then, so that's the base. That's a thing that you learn about in residency, and I've never seen, but there's great videos of it, where people get punched in the chest at the exact amount of right in the R wave or whatever it is, and their heart goes into fibrillation, and they need CPR and defibrillation generally. So it is a traumatic arrest, but it's a special case. Same with crushing, same with direct airway trauma. There's a couple exceptions that they didn't mention. And then isolated head injury. Oftentimes, isolated head injury will lead to respiratory arrest, then cardiac arrest. If you can fix the respiratory and cardiac, defibrillation, you can get them back without doing all this crazy stuff involving blood. Conventional. So this slide was by far the most controversial when I give this talk to the nurses and the people who are the house officers and everyone who's probably not in this room, is external chest compressions. There's no evidence that they make things worse. There's definite evidence that they get in the way, right? So it's really hard to do anything else when somebody's bouncing up on his chest. It's really hard to do good chest compressions when somebody's doing anything else, right? So, I mean, you guys have seen enough medical codes, and there's legions of data about how hard it is to do regular chest compressions when it's just a medical code. It's even harder in a trauma code. So they're really trying to steer you away. They're fine, but just make sure the airway, the blood's being given, the chest is being decompressed. And basically, I've never seen a case where you can do all that and do external chest compressions as well. And these are in pretty hot trauma centers that see 1,000 trauma intubations a year, which is 10 times more than we do here in New Zealand. So basically, most of the guys who do a lot of this find it really hard, even with a dedicated team, to do external chest compressions and the other stuff I just talked about. So you can, but good luck. And if you do chest compressions, it works better to do it inside the chest than outside the chest. Adrenaline, basically the same thing. Additionally, there is some reasonably high theoretical chance that giving adrenaline in people whose bleeding isn't controlled, you kind of don't want that heart started while their tank's still emptying, while there's still a hole in it, right? So you kind of want to do that as after things get going through. So same story with defibrillation. And then, while they're there, if there's an extra pair of hands, if there's some reason that it's not hypovolemia or a pneumothorax, you want to fix that as well. But the chances that it's one of those two things are so high that you need to get moving, right? You only got 10 minutes. See, we did a traumatic cardiac arrest just yesterday in the ED and edited it down like we looked. And you guys can watch this and see what we did wrong. It was kind of.
CQ coming here with a 25-year-old male, stabbed to left side of chest, hypertensive, BP 80, pulse 120, VCS of 13, respiratory rate of 44 and saturation at 88 on 100% O2. Status 1, ETA 10 minutes. So you can read this one.
I heard the trauma bell go off. What's up?
Cool, so we've got a 25-year-old male coming in, stabbed wound to the chest, systolic of 80, pulse of 120, rest rate 48, sats of 88% on 15 litres. Do we make it a trauma call?
Definitely. Okay, let me see if we can get some help.
Can I please have an adult resus trauma call?
Help, please. Ah, Nikki. Hey, you're here. Can you help with circulation? Get ready. We have a penetrating trauma to this chest. Hey, Danny. So we have a penetrating hypotensive stab wound to the chest. Circulation.
Can we just set up Airway, Andy?
Yeah.
Brilliant.
Hey, and trauma to the chest. Can you help? Can you get all the airway drugs?
Yep, no problem at all.
Some ketamine and some fentanyl?
Yep.
And hey, trauma to the chest. Penetrating. Okay. You want to be our airway guy?
Sure.
Look at all this team, man. Hey! Trauma to the chest.
Yep.
Can I help with IV access? Sure. You want to just get the IO in too?
Yeah. So potentially we might have to do a finger for a cost.
Yep. Okay. So why don't you get ready to do that first?
I'll just put CO2 on this bag.
Gonna be back. I might gown up.
Yeah, why don't you gown up? Good.
Andy, do you want me to order some desperate O's?
Yes, please.
4?
4 units of desperate to call a blood bank.
And I'll just get an orderly.
Everyone's dead.
No, you don't want to run over what we've got, but you over here?
Yeah, that'd be great. Let's quickly get this plugged in and warmed up as well.
Just going to move this out of the way from your patient.
Yeah, I can come down here.
Brilliant. So we've got oral airway and we've got nasal airway and initial. We've got a 2 assisted system and heartbeat. We've got 2 heartbeats. And we've got an LMA as well, as a syringe. If we need, we've got a syringe and a 6.5. Yeah, and we've got further.
Excellent. Alright, so plan A, video looks good.
Plan B, it will be treated around and given the right surgical. Just a little bit, so just a little bit impactful, that's great. Just gonna, you got to
Maybe.
there on?
There might be someone threw out the blind.
Oh, blood's coming, isn't it? I've got a scalpel.
Oh, you do?
Sweet. Okay, so it looks like we're kind of ready. Can we just have a quick brief before they get here? So we have a penetrating stab wound to the chest and who's hypotensive tachycardic. We're going to plan for the worst and hope for the best, right? So remember the new guidelines say you got to give priority to circulation at CABC. So that means we've got to make sure we have lines, and then we want to make sure we decompress the chest if there's a pneumothorax or a pericardial tamponade. So, and of course we'll do your airway stuff as well. So let's just go through it again. So our circulation plan is Danny. Do you feel comfortable doing finger thoracostomies?
Yep.
And then if we need to, we can put chest tubes in.
Okay.
And again, do you feel comfortable doing a thoracotomy?
Yeah.
So we haven't done a lot. I've done a couple. We've practiced it, and I've already talked to the theater upstairs. They're ready for us. They're trying to close up, and they'll be down to help as well. Circulation, we have just regular IV stuff.
Yeah, and IO as
And
well.
an IO, and then we also have a big fat central line over here.
Yeah.
And then airway, what is your drug plan? What do you guys want to use?
So I think we should give some sucks, 200 regardless, and if he needs it, some ketamine.
Okay, cool. And then you have your plan.
So we're doing a learning scope first.
Okay. Cool. So remember, so CPR is of secondary importance, adrenaline is secondary importance for the worst case scenario.
Yeah.
Now it's totally different, right? This guy's probably going to come in wide awake and just fine. So, but we'll plan for the worst here. Okay? So anything else? So you guys are the airway team, you got it. You got some chest tubes and finger thoracotomies. And you guys are ready for access. And we have blood has arrived.
Yep,
We're not going to give any saline. If we have some more time, the sucks is drawn up, the ketamine's drawn up, and if you guys want, we can drop some adrenaline too. Okay? Hey!
Hand over before or after we drink.
Before, please.
Alright, 25-year-old male, no details, we just scooped and ran. He's got a stab wound to the chest. He's hypertensive tachycardic, got a GCS of 5. We haven't done any treatment en route.
Okay, cool. Let's just bring him over, but let's look at his back while we go. Let's roll towards you guys. Yep.
Alright guys, you're gonna ready to roll up into the side. On 3, going happy. 1, 2, 3.
No, back there. Okay, cool.
Down 3. Okay, let's get him across. Okay, scoop under. We'll just go on the sheet. Happy?
I think we're okay with just the sheet.
Just on the sheet, get the board out. We're gonna go across all the way on 3. 1, 2, 3. Alright.
All right. IVs. And let's have GCS now. Sort of moaning a little bit.
Moaning a little bit.
Danny, can you just make sure we have a pulse? Actually, Kevin, could you make sure we have a pulse on the femur?
He is breathing.
Okay.
Feel a faint pulse.
Moving a little bit. We have 0 IVs in right now.
We've just got one in.
Give one IV in.
So Danny, can we listen to his lungs and see what we got? And let's try for another IV, please.
Yeah.
And
From the other side.
You still have a pulse?
We have a weak femoral pulse.
Okay, let's get the ultrasound in here. I'll get it.
He's got reduced air entry on the right hand side.
And you feel comfortable just looking at his heart and seeing what you can see? So why don't we get a quick pericardial?
Yeah, he's not breathing properly.
Okay.
Pulse.
I've lost my femoral pulse.
Okay, ignore that ultrasound, Danny. Can I ask you to put in just a finger thoracostomy?
Sure.
So we have 1 IV again?
I'll put IO in.
And let's put an IO in. We have no pulse, is that right?
Correct. There's
Okay.
no pulse. He's not breathing anymore.
So we're not going to do CPR, remember?
One hose,
One hole.
and there's his.
And there's a big hiss. Can we recheck a pulse?
Would you only get on intubated there?
Yeah, go ahead and put that tube in. Can we get the socks anyways though?
We still no pulse.
Okay,
Can
let's
I
just
someone
get
to do the
in.
ultrasound? Mate, are you happy?
Shall I get the thoracotomy tray ready?
Yeah, could you get the thoracotomy tray ready? And I'm just going to look at his heart.
Saxes in.
Flex is in.
IO's in.
IRO's in. So we have 2 lines. Is blood doing it yet?
Second hose on, there's a his. We got 2 holes now.
Blood's going in.
And so I see a big nasty pericardial effusion. And we still don't have a pulse. Can we open up that thoracotomy kit? You
Sure.
want to help Danny with the thoracotomy?
Yeah, push it out, come up.
I don't know who your hand.
So I'm gonna.
Cuffs up.
Go.
So airway secured. We have 2 lines. We've decompressed the chest. We have a single stab wound to the chest on a 25-year-old guy. Danny, let's open this
Are you
chest.
happy?
Yep.
Okay.
And we have blood going, eh? Good.
Making it taut now.
Yep.
Do you want to get that second unit and then we can go on to the IO?
Figure out how to get in there. It's a total pain in the ass. Aha. Nice.
Taut.
Yeah. And blood's hanging. One through the IL, one through the other line.
Yep.
Danny, once you got that in, let me know if you want me to advance the tube into the right.
Yep.
I get the syringe.
We're in now tonight with the
There's the
EP2.
syringe on the cuff. We might need to advance.
Louis, can I get you to the right side of,
Main stem.
Yeah,
Main
we
stem
got-
that, Louis.
Yep.
And we're pumping in that blood as soon as we can. As fast as we can. Do you see the heart yet, Danny?
yep, no. Wait, can
Advance
I
the
get
tube.
you to hold on?
Nikki, can you go and help hold the retractor? You're too dirty. Somebody needs to go down. Okay. You guys got it?
Okay, I can see the heart, I can see the springs nerve. We're picking up the pericardium.
Does it look like there's blood around that pericardium?
Yeah. So I'm just looking at how there's a big gash coming out,
Yeah.
and I can't see any holes in the heart.
Yeah. Can we go ahead and give a milligram of adrenaline now?
Okay. And what's his vital signs now?
Do you have a pulse?
We have a pulse.
Okay, so Danny, find the hole in that heart, eh? Oh, you see a hole?
If there's a hole,
Can you find to make sure there's not 2 holes in that heart?
sure.
And it's pumping. You see a pumping heart?
Yep. It's
Very
pumping
good.
right now. I need to
And,
get it
oh
out.
wow, he's alive. So maybe we should give that ketamine now, eh? So let's give 50 ketamine, please. And
We're gonna go.
Kevin, can we give an IEC catheter?
Yeah. 12 French.
Is all that blood that we've got gone through?
Yes, we can
Oh, wait, order some
keep
more.
pumping some more. Could you order some more? And actually, have we sent blood? Have we taken a blood sample?
That's gone on from the
Okay.
Labeled correctly, of course?
Yeah.
Okay, great.
That's it.
What do you think? Good?
Yep.
So, okay, so hey, let's keep going, guys. Sorry. We're gonna continue this resuscitation, right? You're gonna keep trying to stop the bleeding out of that
Yeah.
heart, Danny. You guys do great. Surgery's gonna come down.
Yeah.
They're gonna help us with that. We're gonna keep the airway seam secured, right? Where breathing is adequate, right? He's ventilating okay. We'll probably need better access. When we have someone else here, we'll probably put in a central line. Okay, a big fat central line here. But then you just keep paying attention to that heart, and we'll keep running the rest of this resuscitation. We're gonna keep pouring in blood until we get a good blood pressure, then we'll slow it down. Can we give him 1 gram of tranexamic acid as
Yeah.
well? And we're gonna sedate him just using ketamine only, small aliquots. And I guess we can, is he moving around too much? Do we need to paralyze him? No.
No.
And
Okay.
cardiothoracic.
And cardiothoracic. So I'll call surgery and tell them what a bunch of butt kickers we are here. And he'll probably go up to theater here. And that's sorry. Cardiothoracics can come here to help us, but the surgeons upstairs with the big bike can do most of the stuff. Okay?